Good morning. Our talk today is about genetic disorders among Arabs, diagnosis and prevention. My name is Rami Jarjour, and I am a clinical geneticist from Syria. Before we start, I would like to give you a short CV about myself. Actually, I graduated from the Faculty of Medicine, Damascus University. Then I got my MSc in medical genetics from Glasgow University and my PhD in molecular genetics from Glasgow University as well. And I've been working in the clinical genetics unit in Damascus, and I am currently the head of the human genetics division. I'd like to thank Dr. Katia for inviting me to give you this talk today, and I'm really very grateful to her, and she is really a fantastic person. Well, this is the outline of our lecture today. First of all, we'll talk about genetic diversity among Arabs. Then we'll discuss why do we have lots of genetic disorders in the Arab world. We'll talk later about consanguinity in Arabs, and I will discuss a little bit about the most important autosomal recessive disorders among Arabs. We'll talk then about genetic testing, prevention programs, and we'll talk about this catalog for transmission of genetic disorders in Arabs, CTGA. This is the map of the Arab world. Actually, the Arab world consists of 22 countries, and actually the population of the Arabs around 300 million people, and it represents about 5% of the world population. Uh, Actually, the Arab world is very diverse regarding genetics and regarding ethnicity and regarding religions as well. So we have Muslims, we have Christians, we have Arabs, we have Kurds, Druze here in Syria, in Lebanon, in Palestine, or we have Berbers in North Africa. We have Armenians, Circassians, Jews, and other minorities as well. So this genetic diversity maybe contributes to the genetic disorders in the Arab populations as well. Actually, most of us know that the genetic disorders are very common in the Arab world. So what are the reasons behind that? The most important reason is the high consanguinity rate in Arabs, which is really very high. We'll talk about that later on. Then the high prevalence of mutations regarding hemoglobinopathies, G6PD, metabolic disorders, which contributes to the high frequency of genetic disorders in Arabs as well. Then the lack of the public health measurements from the governments regarding prevention of the genetic disorders. Well, consanguinity is really very high among Arabs, although it's not very common in the Western countries, but actually it's really very common in the Arab world. And actually the rate ranges from 25% in some countries to 60 or 90% among Bedouins in some regions in Kuwait and Saudi Arabia. Generally, we can talk about 40% rate of consanguinity among Arab countries. Here in Syria, it really even ranges from 20% to 70% in some of the western part of Syria as well. Well, consanguinity actually happens between first cousins and mainly paternal first cousins, and sometimes it might be more complicated than this. So it might be double first cousins, or actually it might be more complicated than this as well. So the fathers might be brothers, mothers are sisters as well. The grandfathers might be brothers or cousins. Grandfathers might be brothers or cousins too, which makes practicing clinical genetics here in the region so complicated. Actually, consanguinity is more common in Muslims or among Muslims rather than Christians. It has nothing to do with the religion itself or Islam. Actually, Islam discourages consanguinity, but it doesn't forbid it. This map here shows the high consanguinity in Iraq, in Saudi Arabia, in Sudan, in Morocco as well. But the other countries is very high, but those four countries are the highest rate, have the highest rate of consanguinity. And this chart here actually compares the consanguinity in the Arab countries with the West in the United States and in Europe, and we can see there is a big difference in the rate of marriages or consanguineous marriages between those countries. Well, this map actually compares the consanguinity rate in the Arab region and in Pakistan, in Iran, in India, in Turkey, compared to the other regions, and we can see we have the highest rate of consanguinity in this region here. And because of the high rate of consanguinity marriages in the Arab region, that makes the autosomal recessive disorders are very high among Arabs too. This is a list of the autosomal recessive disorders common in Arabs. The most important globinopathies, familial Mediterranean fever is quite common too here, particularly here in the Middle East. Muscular dystrophies and myopathies are quite common in bone errors of metabolism. Cystic fibrosis is quite common. Talk about these diseases later on in the lecture. The hemoglobinopathies that are common in Arabs are sickle cell diseases, thalassemias alpha and beta. Well, beta thalassemia is quite common here in the Arab countries, and actually the carrier rate ranges from 1% to 11%, which is very high. Actually, we can see here in this chart the mutations. The most important or the most common mutation is IBS 1110G2A, and most of the mutations are splice site, frame shifts, and some of them are located in the promoter region. Well, this chart here actually shows how diverse are the beta thalassemia mutations in the Arab region. For example, in Saudi Arabia, we have 49 mutations. Here in Syria, 44 mutations. In the United Arab Emirates and Algeria, we have 27 mutations. So the spectrum of beta thalassemia mutations in the Arab world is very diverse. Well, this is one of the studies that I did about beta thalassemia here in Syria, and we can see how many mutations that we have here. And of course, we couldn't actually cover all the mutations or diagnose all of them. And you can see here about 8% of the mutations were not detected by the technique that we used at that time. Actually, alpha thalassemia is also quite common here in the Arab region, with frequencies ranging from 1% to 85%, and the highest rate of alpha thalassemia is in the Gulf region. This mutation, alpha 3.7, is the most common mutation here in the region. Well, there are some other mutations as well. Sickle cell disease is also quite common here in the region, in the Arab region. And actually, we have subgroups of sickle cell disease, sickle cell anemia, HBSS, hemoglobin SC, and sickle cell beta thalassemia. That means the patient carries one sickle cell mutation and one beta thalassemia mutation. And the rate of sickle cell trait or the carrier rate of sickle cell mutation ranges from 0.3 to 30% in the Arab world. G6PD deficiency, or actually it's an abbreviation of glucose 6-phosphate dehydrogenase, is also an example of an X-linked hemolytic disease, and actually it's quite common in the Arab world. But G6PD is the most common disease all over the world with about 500 million uh, patients all over the world. G6PD have variants of mutations, but the most severe one is G6PD Mediterranean, which is quite common here in the Middle East, and it causes hemolytic crisis, particularly after eating fava beans. Familial Mediterranean fever, or FMF, actually is one of the most common diseases here in the Middle East, particularly in Syria. Actually, we can see it here in Syria, in Lebanon, in Jordan, in Palestine, and you can find it as well in Iraq, Kuwait, Egypt, and Saudi Arabia. Maybe it's also present in other countries like United Arab Emirates, but it's really underdiagnosed in those countries. Uh, Actually, it's common in Arabs, Armenians, Turks, and Jews. And the patients actually suffer from episodes of fever, abdominal pain, chest pain, arthritis, and they might develop amyloidosis, which ends up with kidney failure. The good thing about familial Mediterranean fever is that it can be treated with colchicine. It's really one of the rare genetic diseases that has a cure. Familial Mediterranean fever has a wide range of mutations. The most important mutation is M694V, and most of the studies actually say that familial Mediterranean fever is quite common here in the south of Syria, and from the south of Syria, it spreads to all other countries. This is one of the studies that I did about familial Mediterranean fever, and we found that Syria has the highest carrier rate in the world. Muscular dystrophy and myopathies are also quite common here in the Arab region. Spinal muscular atrophy, or the other name of it is Werding-Hoffmann disease, is quite common with an incidence of 1 in 1,000 to 1 in 5,000, which is really one of the highest rates of spinal muscular atrophy in the world. We can see also Duchenne muscular atrophy, and I have this publication about Duchenne muscular dystrophy, or DMD, in Syria. Some of the inherited central nervous system disorders are neural tube defects, Charcot-Marie-Tooth, Friedreich's ataxia, malformations, leukodystrophies as well. Inborn errors of metabolism are quite high. To be honest, the rate of metabolism disorders here in Syria, or inborn errors of metabolism here in Syria, is a bit high. Most of the cases that I encounter are inborn errors of metabolism. One of them is phenylketonuria, homocystinuria, amino acid metabolic disorders, Niemann-Pick disease. Cystic fibrosis actually is one of the most common disorders in the West, particularly in Europe and in the United States. And actually, it's a quite common disease in Caucasians. Uh, Actually, it was a bit weird that cystic fibrosis is not very common in Arabs, because Arabs are Caucasians as well. And actually, what happened that initially it was diagnosed in a Lebanese family in the 60s of the last century, and after that it was diagnosed in lots of other countries in Syria, in Saudi Arabia, in United Arab Emirates. So we found out after that the diagnosis that missed out because of the mild manifestations of the cystic fibrosis in the Arab patients, as the situation and the weather is very hot and humid. So the actually the clinical features of cystic fibrosis were not very clear in the Arabs, and because of that, it was underdiagnosed. This is actually a study I did about cystic fibrosis in Syria. Actually, I could collect 25 cystic fibrosis patients, and we can see here in this table the most common uh, mutations. Delta F508 is the most common mutation all over the world causing cystic fibrosis. The most common inherited renal diseases in the Arabs are polycystic kidney disease, inherited nephrotic syndromes, and hyperoxaluria type 1. Deafness or inherited deafness is quite common actually in the Arab region because of, as we said before, of consanguinity. And we can see here from this map that the most common variant is 35DLG, which is quite common in the most of the Arab countries. Familial hypercholesterolemia is quite common in the Arab region, and the rate of familial hypercholesterolemia is 10 times higher than in the other parts of the world. And there is a very common allele or variant which is called the Lebanese allele or the Lebanese variant, which is a bit high in Lebanon and Syria too. Osteoporosis, which is clinically characterized by renal tubular acidosis and cerebral calcification, is also quite common here in the Arab world, particularly in Saudi Arabia and Arab Peninsula, and the rate of the mutations of osteoporosis is a bit higher than other countries in the world. Non-disjunction syndromes like Down syndrome actually were reported 4 times or more in Kuwait, in Saudi Arabia, and probably this high rate of non-disjunction syndromes like Down syndrome goes to that mothers give birth to their babies at the age of 40 or over 40 years old. Now we have finished talking about the genetic disorders among Arabs. We talk about genetic testing. So how are we going to our samples for genetic testing? Well, of course, the much easier way is to take a mouthwash or a buccal swab for getting some cells and isolating the DNA. The peripheral blood is quite good too. Maybe it's a bit invasive compared to the mouthwash. We can take biopsies from cancer. For prenatal diagnosis, we can use chorionic villi or amniotic fluids to get some cells from the embryos as well. And Gossi card is quite good too because it's just a piece of paper that we can collect blood from newborn babies in order to do the genetic testing later on. Well, there are too many techniques used for genetic testing. One of them is restriction fragment linked polymorphism, RFLP. This technique actually find out if there is a presence or absence of a restriction site within the region that contains the mutation itself. So we do a PCR, and after that we can digest the PCR product with a restriction enzyme to find out if the restriction site is present or absent because of the mutation is present or abolished. It's quite easy and cheap, and it's quite common to have this technique used in the genetic labs all over the world for diagnosing genetic disorders. The other technique that is used for diagnosing genetic disorders is allele-specific PCR amplification ARMS, or this is another abbreviation of it, ARMS. Actually, this technique is using only PCR primers. For example, we use one forward primer and two reverse primers, and the difference between the two reverse primers is just only one nucleotide regarding the mutation that we are looking for. It's much easier than RFLP because it only consists of PCRs, and there is no restriction enzyme. Actually, in my lab, actually, I use this technique quite common as well. Well, RFLP and ARMS are quite good for diagnosing a single point mutation, for example, but they are not very powerful when we talk about the genome or diagnosing a mutation regarding the genome that we do not know where it is located. So because of that, they developed a new technique which is called next generation sequencing (NGS) in the last few years, which are very powerful technique to diagnose unknown mutations. Actually, we might cover exons, or we might cover some genes, which is called panel of genes. We might also cover by NGS whole exomes in might actually sequence the whole genome itself. So how can we decide what test is better for our patient? Is it a single gene test or a panel of genes or whole exome sequencing or whole genome sequencing? Well, the answer actually depends on actually the disease itself. For example, we choose a single gene test when the clinical diagnosis of the genetic disorder is quite clear. For example, if the patient has cystic fibrosis, so we can do, for example, RFLP or ARMS for the CFTR gene, or we can sequence the whole CFTR gene itself. We can use a panel of genes when the diagnosis, clinical diagnosis of the patient is not clear, but we have a phenotype. For example, if we have a patient with myopathies or muscular dystrophy and the clinical diagnosis is not clear, we can use this test, a panel of genes, in order to diagnose the disease and detect the causing mutation. We use the whole exome sequencing if the clinical diagnosis is not very clear or the clinical symptoms of the disease are not very compatible with any syndrome that we know. The whole exome sequencing actually is quite good because it covers about 1 to 2% of the whole genome of the patient. Mainly, actually, it covers the coding exons. And we all know that most of the causing mutations of a disease occur in the coding exons. So generally, it's quite enough to use whole exome sequencing to diagnose a genetic disorders. Anyway, actually, the companies that we do the whole exome sequencing say that it may diagnose about 60 to 70% of the most of the genetic disorders by this way. If we cannot diagnose it by the whole exome sequencing, we can move on to the whole genome sequencing. Actually, the whole genome sequencing is much powerful than the whole exome sequencing because it covers the coding regions, the exons, and the non-coding regions as well, or as we say, the introns. So it mainly covers about 98% of the genome of the patient, which is quite enough to diagnose any disease this way. Actually, the big difference regarding the price is the only problem that prevents us from using whole genome sequencing. The whole exome sequencing costs about 1,000 US dollars, while the whole genome sequencing actually costs about 4 to 5,000 US dollars. Actually, I have been using next generation sequencing or whole exome sequencing quite a lot in the last few years because it's really a powerful technique to diagnose my patients. So when we get the results are reported like this: pathogenic, likely pathogenic, uncertain significance, likely benign, benign, according to comparing the results with the database that it's online. What do we mean by VUS or variants of uncertain significance? That means that the result that we got or the variant that we got from the whole exome sequencing or whole genome sequencing are not found in any database when we searched the database online or whatever. Uh, Generally, most of the variants of uncertain significance are benign, but we have to do quite a lot of work to prove that. How can we do prenatal screening for Down syndrome? There are too many ways actually. One of the easiest and non-invasive ways is ultrasound, but we can, after using ultrasound, actually confirm that by using the triple test or the quadruple test, which contains alpha fetoprotein test, estriol test, CVS test, inhibin A, PAP, PA as well. And of course, all these tests regarding Down syndrome, if we talk about ultrasound test or the triple test or the quadruple test, are screening tests. That means they are not enough to diagnose the Down syndrome itself. So if we got a positive result, we have to confirm it by prenatal diagnosis using CBS or amniotic fluids. NIPT actually is a new and a good technique to diagnose Down syndrome and some other aneuploidies or chromosomal aneuploidies. It is called non-invasive prenatal testing. The good thing about NIPT that it's non-invasive, so there's no need to use invasive techniques like CVS or amniocentesis. So we take some blood from the pregnant woman, and actually we know that the blood of the pregnant woman contains some cell-free DNA, which comes from the embryo or the placenta itself. So we can use this DNA to diagnose Down syndrome or other aneuploidies as well. We can take some blood around week 9 of the gestation, and it's quite good, as we said, to diagnose Down syndrome, other aneuploidies, fetal sexing too. Now we have finished talking about genetic disorders among Arabs and how we can diagnose them. So, since we don't have any good cure for genetic disorders, so the best way is to prevent them by using prevention programs, and premarital screening is one of the best programs that we can use for that, particularly in the Arab region, because in the Arab region, actually, the abortion is not very acceptable. So we should do the premarital screening, so every man and woman who are going to marry, they should go and genetic testing. In United Arab Emirates, in the past, the premarital program used to cover for only sickle cell anemia and thalassemia. But starting from this year, actually it covers 570 genes and 848 genetic disorders, which is a very powerful program to prevent getting new cases of genetic disorders in United Arab Emirates. In Syria, actually, we only still cover for thalassemia and sickle cell anemia. The family-oriented approach, actually, we use it when we actually in the family we can diagnose a recessive disorder like cystic fibrosis or thalassemia. So we have too many cases, like we can see here in the pedigrees, and we have too many consanguineous marriages, like we notice in the two pedigrees. In this case, we have to go for one of the patients, diagnose the mutation, and of course, we should do some other techniques later on, like PGD or whatever. Neonatal screening actually means that we can take some blood from the newborn babies, and we can do some genetic testing or some other tests regarding some of the diseases that can be prevented or treated later on. For example, the American College of Medical Genetics recommends screening for 29 disorders in the United States. In the UK, the screening program covers 9 genetic disorders like sickle cell anemia, cystic fibrosis, hyperthyroidism, and some inborn errors of metabolism. In the United Arab Emirates, the neonatal screening actually covers phenylketonuria, congenital hypothyroidism. The antenatal screening for chromosomal and congenital malformations and other genetic disorders, actually it's quite common to use this program in the West, but it's really not very acceptable in the Arab region because this program should end up with abortion and termination of pregnancy, which is not very acceptable here in the region. Prenatal genetic testing is not acceptable here in the region, as we said, because of the ethical and legal and social and religious issues. So the best way is to use PGD for prenatal genetic testing. PGD, in my opinion, is the best for the Arab countries because actually there's no termination of the pregnancy in this case. So in PGD or pre-implantation genetic diagnosis, we should do an IVF in vitro fertilization, and after a few days we can take a biopsy, and this biopsy can be screened for a genetic disease itself, or we can do some other testing or genetic testing regarding other diseases, or we can do it for the aneuploidies as well. Finally, I would like to introduce this website, which is really an excellent website about genetic disorders in Arabs. It's the catalog for transmission genetics in Arabs, CTGA. It's based in the United Arab Emirates, and you can search whatever disease you want and get lots of information about this genetic disorder in Arabs in general, with lots of statistics and reference data. And this is a very good and excellent, actually, reference book about genetic disorders among Arabs by Dr. Ahmed. Or maybe it's a bit old now because I think it was published in 2010, but it's really the only reference book about genetic disorders among Arabs. Finally, I would like to thank you for listening to my lecture, and in case of any question, you can contact me directly by Facebook and Messenger or Jarjur1 or by WhatsApp on this number. Thank you very much to you all.